Hello everyone, this is Bob Browner. I'm recording a summary of some baseline data for some of our health disparities on racial and socioeconomic lines for Lincoln, Nebraska. This is part of a CDC-funded grant that will be over the next 5 years, and it's designed to reduce racial and ethnic health disparities. The intent, the grant is funding mostly a focus in the African American and Hispanic communities. However, we hope that it will indirectly reduce disparities for all of Lincoln's residents. This grant funding goes to fund 13 other organizations in addition to Partnership Healthy Lincoln. So this will align a lot of folks across the community to hopefully reducing these health disparities over the next 5 years. And you can see all the people involved here. We have three sources of data that we'll be using to evaluate how successful this is and guide our efforts. The first source is Lancaster County birth data. This comes from birth certificates that are produced on all children born in Lancaster County, and there's usually somewhere in the range of 4,000 to 5,000 births in Lancaster County. So a good sample size of information on the births and the health of pregnant women and children in Lincoln, Nebraska. It's put together by Tommy George, who's the Assistant Public Health Epidemiologist there, and we'll be updating and compiling this data annually. The kind of data we have here basically goes back 11 years. We should have 2018 data in the next month or two, which will update this. So first, some good news. One is on breastfeeding rates. What you'll see is that over time, Lancaster County women are increasingly wanting to breastfeed. We started at 81% in 2007. Now we're over 92%. And so this is a great trend to see that the message that breastfeeding is good for you is getting across the community. We'll see improvements across the board. However, we do see some disparities, for example, on socioeconomic lines. Women with private health insurance, 95% want to breastfeed, but while women on Medicaid, a little lower at around 88%. There's also some racial and ethnic differences, especially with the African American population being quite a bit lower. So this tells us that we need to focus more of our efforts here if we want to make a difference. And a lot of these African American women are also low income and on Medicaid, and so it's probably a combination of factors that are leading to this. Some good news is that our cesarean section rates do not show any disparities on either racial or socioeconomic lines, and so nice to see that this is at least not affected by things like that. Gestational diabetes, though we have seen quite a bit of an increase, it's basically doubled in the last 10 to 11 years. We've gone from 3.4% up to 6.3%. It's gone up across ethnicities and related to the obesity epidemic, which is a nationwide issue. We also, though, see probably there is somewhat of a genetic component where our Asian population does have higher rates of gestational diabetes. Low birth weight by maternal race, you'll see that unfortunately for African Americans, this does stand out that they are significantly higher. Overall, the trend is not that much up or down, so it doesn't seem to be anything worsening. However, we do have a large racial and ethnic disparity here. Also, you'll see that there is an income disparity. So women on private health insurance have lower incidence of low birth weights, whereas women of lower socioeconomics have higher. So this is something we definitely want to try to figure out how we might address over time. Like low birth weight, gestation-related delivery preterm births also show similar types of patterns. And so you'll see that women on Medicaid have higher rates of preterm birth, and again, it's higher in the African American population. So there's probably a combination of a little bit of a genetic influence, but also socioeconomics in here. Most of the evidence shows that things you can do to reduce this over time is early access to prenatal care and better prenatal care. We also do have, though, good measures on that as well. So part of the birth certificate includes how many prenatal visits a mom had, and also how often and when she started her prenatal care. And so we have a couple numbers we can look at here. What we've seen is that over time, yeah, there is a change. There is a difference in that private health insurance to women are getting more prenatal visits than women on Medicaid. This could be an educational issue, could be an access issue, and we do see that there are some disparities based on race and ethnicity as well. If you look over here, though, or trend over time, you do also see that this has fluctuated over time. What you're probably seeing here is that the improving economy led to better prenatal care, better access. Then the Great Recession hit, and we saw a worsening of this, probably due to socioeconomic factors. And as the economy stabilized and started to improve, it looks like we might be getting a little bit better here. Also, for access to first trimester prenatal care, we are seeing that there is a difference in private health insurance versus Medicaid. In theory, there shouldn't be a problem with Medicaid because all women in Nebraska are under what's something called presumptive eligibility. So a woman who has no health insurance and shows up to a maternity care provider, they can get covered in the next couple months, and so they'll be treated as if they have health insurance until they get on Medicaid, and they will be able to get on Medicaid. However, there may be some lack of knowledge among women who have no health insurance that we have presumptive eligibility in Nebraska. Nebraska. So maybe if we did a better job of educating the general public that yes, as soon as you get pregnant, you can see an obstetrician or a family doctor or a midwife in town, that maybe they'll won't wait as long, and maybe we could reduce this over time. We also do see that there are some differences on racial and ethnic lines. So our minority population, we're having more problems with women not showing up in time for prenatal care. And so if we could get them to prenatal care sooner and get them more prenatal care, we might be able to reduce some of those preterm births and low birth weight babies here in Lincoln, and which also will decrease infant mortality. There's also another form of measuring this where it's a combination of both early access and adequate number of prenatal visits, again showing pretty much the same things, that there are differences on socioeconomic lines as well as racial and ethnic lines. So one of our things we'll work on in this grant over the next 5 years is see what we can do to reduce these over time. Our second source of data comes from Lincoln Public Schools health data. So Lincoln Public Schools has been doing aerobic fitness testing on all its kids for years. We've started compiling this on a district-wide level for the last 10 years, and so we have a long longitudinal set to see kind of what's happening with the fitness of our kids over time. This is important because fitness is one of the most important risk factors, and on top of that, kids who are aerobically fit also do better in math, reading, and science, and so there's a double reason to be focusing on fitness in elementary and middle schools. This data is compiled annually by Dr. Matt Avey, who's the head of the Health E&P curriculum at Lincoln Public Schools, and Rob McIntarfer, who works in the evaluation department, and myself. We've been working on this data set for the last 10 years, and we compile this annually. What we see over time is that we've actually made quite a bit of improvements over time within Lincoln Public Schools, starting from where we first had complete measurement in 2011. We've seen a nice increase in the amount of our kids that are aerobically fit. We kind of leveled out for the last couple of years. In the last year or two, we've seen a little bit of a decline, which is a little concerning, and so we're right now studying why that might be the case. Most concerning is that we see a pretty significant drop in Hispanic kids the last 2 years. Hopefully this is not a long-term trend, it's only a blip, but there is some concern nationally that we are seeing some decline in health statistics in the Hispanic population. The leading theory is that it's due to the political climate and fear that's isolating our Hispanic population. For example, a recent study about DACA recipients is that when DACA came in place, and they were able to get jobs and have some clarity on their role in the United States, they saw huge improvements in the health of the population up and through 2015. But then when the change in political winds after 2016, it looks that we may have lost most of those health benefits of DACA on the population. And it's not just the DACA recipients, but it's also been seen on their children. So unfortunately, over the last couple of years, we've seen an erosion of those health benefits for the eligible immigrants and their children. And so there is some evidence that this, what we're seeing from a decline in fitness in the Hispanic population, could be part of a broader trend and something we probably need to focus on in our community. Also with this data, we have large numbers and data that we can break down by both ethnicity and gender. You'll see that girls have lower fitness rates than boys, so we do need to pay particular attention to girls because we also see a gender disparity here. By giving us numbers, though, it also tells us, how much we need to do to work on this. So for Hispanics, for example, we have 2,000 Hispanic children between 4th and 8th grade. If we wanted to remove disparities, it'd be roughly getting 200 more Hispanic kids physically fit and passing this PACER test. Well, we could do that by just reaching a couple of schools. So, for example, our 3 middle schools with our most Hispanic kids, Kohler, Goodrich, and Park, those 3 schools alone have over 500 Hispanic children. If we could do something with just those 3 middle schools, we could potentially reduce this disparity, for example. Or if we look at the LPS Elementary Schools that have the most Hispanic students on the K through 5, focusing on just 7 elementary schools, we could potentially impact 921 Hispanic kids. That could be that 200 kids that we could get more physically fit and reduce that disparity in fitness based on ethnicity over time. Our third source of data we're going to look at is safety net clinics, and so 3 clinics have started working with us to compile some of their clinical quality measures, Blue Stem Health, Lincoln Family Medicine Center, and Nebraska Urban Indian Health, which serve a lot of our Medicaid, low-income, and refugee communities and cover most of the health care in our medically underserved area of Lincoln, Nebraska, have been great to work with, and they're actually taking their data, like for example on cancer screening or diabetes care or blood pressure, and we're working with them to see if there are differences on racial and ethnic lines. And so, for example, might have, let's say they've got 40 or 50 of these out-of-control diabetics that are Hispanic, might reach out to El Centro's de las Americas community health worker and hopefully work with them to get these diabetics under control. So hopefully we'll see some improvements in this over time as well. So hopefully this is helpful. If you have any questions, shoot me an email. We'll be working on this data every year for the next 5 years and hope to see some improvements. And the more people we have working on this across the community, the more likely we are to succeed.